Okay, everybody. Hi, happy Tuesday. I'm Dr. Roney, and this is Dr. Shankar.
Hi there.
Yep, Dr. Shankar is the new doctor, one of the new doctors here. So she's going to be on with us tonight. We're going to do a very good intro, and then we're going to answer, do a Q&A session, and we'll just let it flow, right? So I know everybody's a little nervous, right? Usually, but it's okay. There's no reason to be nervous. We'll definitely we'll handle it, and everybody out there in the audience is just we hear feedback all the time that they just appreciate the information. So so anyway, Dr. Shankar and I will take the reins. Dr. Keneally will be up probably in a half hour, and she'll sit in too, and we'll all have a really good discussion and answer as many questions as we can, as we always do. As you know, I want to take the opportunity to welcome you if you're new, and then if you're returning, also welcome back. Appreciate the support, really appreciate the feedback. I think it's been super helpful. I feel like this cancer conversation, my opinion, has done exactly what we had set out to do, which is just educate and inform and share knowledge and help people, get this information that they might not otherwise be exposed to, which can help them tremendously, right? So, we certainly appreciate the support and the feedback. I think it's been great. So it's accomplishing the goals that we set out a couple years ago when we started this. We talked heavily about after COVID and the way COVID was handled in general. We felt like there could have been way more knowledge spread. There could have been a lot more teaching on health, just to the community at large. But didn't feel like that happened. So we're like, well, we're going to do something about it. Okay. So without further ado, let me go through with you just briefly a little intro. If you're new to this, our 4 pillars. I know a lot of you that are on here each time are probably tired of hearing it, but it serves such a great purpose that a lot of the new patients that come in tell me directly that they came here because that there is a plan. It's a very detailed plan, and there are the execution of it, and there's a quarterback or quarterbacks here that we're not leaving somebody to do all their own research and to try to figure all this out. Where we did a lot of that, we take you through these 4 pillars, and we know that we have to work through that entire process and dot the I's and cross the T's. So when a patient comes in, they know that they can just heal and not have to worry about, am I doing this right? Am I doing that right? So I think that's such an important part of this because so many of you are out there trying to figure this out on your own, knowing that you have blanks to fill in. You're just not 100% sure what those blanks look like. So I'll do a brief overview of the 4 pillars. The first part of this process is testing, right? So we want to make sure that we're dialing in the testing as it relates to cancer as much as possible. A couple of the tests that I feel really good about within the what they call the liquid biopsy testing, as an example, DATAR. The DATAR test can look at chemo scales and repurposed medication that the cancer cells are most sensitive to, right? And with that, then a very specific protocol can be put into place to dial in those repurposed medications that help starve the cancer, which I'll talk about, and as well as what chemo agents might be best suited for the cancer cells that you have as an individual. So it's kind of like you want to hammer the nail once. We want this data to be able to help us do that and dial it in as specific as possible. And then there's a test, just as an example, the Fulgent test. The Fulgent test can look at immunotherapy markers that if, say, hypothetically PD-L1 or HR2 are sensitive or positive, or the markers are there, that means Keytruda, for example, can be a really effective immunotherapy. So these tests, the point I'll make is these tests can dial in the specific chemo or immunotherapies to your cancer, as opposed to just a general, this is what we do, this is standard operating procedure. Sometimes they match really well. But again, to be able to get the best outcomes, we want the specific objective data to be able to guide us. And I think that, just a quick example of the testing, that's a really important part of this process, to be able to dial it in. There's other markers, there's other cancer markers that we look at for sure, but just for time purposes, I'll just highlight those two as some of the top priorities that we want to look at. And then also in the testing world, we want to look at causes, right? So there's cancer markers and liquid biopsies and things like that, but we also want to start looking at those causes. And so the testing is very specific to you as the individual. And that's the main point I want to get across. The second part of this 4-pillar plan is starving the cancer and killing the cancer. So starving the cancer would be using, say, a ketogenic diet and understanding that glucose feeds cancer. When you form ketones, right, instead of glucose, the ketones don't feed the cancer. So that's why somebody would use a ketogenic diet. And we'll talk a little bit about diets later. It's not necessarily for everybody because there's some factors that we want to analyze individually that would preclude somebody from doing that type of diet, and we'll talk about that, right? However, it is a very well-used strategy to help slow down the feeding of the cancer, as well as something called repurposed medication. So the repurposed medication, the top ones would be metformin, and there are things like fenbendazole and menbendazole, some of the antiparasitic meds. There's antibiotics that could be used. There's statin meds that could be used. Now, having said that, in order for us to dial it in, some of the testing that we just talked about help determine the sensitivity of those drugs to the cancer cells. So we can get much more accurate, if you will, which means it's going to be more beneficial to you, the individual. So repurposed meds are a big part of the STAR phase, as well as, say, a ketogenic diet, and also potentially pulsing what they call the glutamine, because those glucose and glutamine feed the cancer cell. So that's the STAR phase. The kill phase would be anything in the conventional world, like chemosurgery, radiation, immunotherapies, low-dose chemo that we do here. All those are very relevant and a lot of times necessary, right? So I point this out. A lot of patients come here and they'd really love to do the 100% natural approach. And look, we'll meet you on common ground. We'll try to do that, but I will tell you, we will use the objective data as well to guide us. And if we're seeing things that we think might need more ammunition, we would at least mention that. But it's been my experience, and Dr. Shankar, you may chime in on this, it's been my experience that killing cancer, if you will, with an all-natural approach, although I've seen it in the literature, I know it can be done, I'm not sure it's the norm. I think it might be the exception, not necessarily the norm. I'm not sure what you have seen, but I think a lot of times we're going to need the heavy hitters, the surgeries, the chemos, the medications, things like that.
Yeah, I think, when you look at cancer, I've been in conventional medicine mainstream for over 25 plus years now. And our approach to cancer is to address the actual cancer either surgically by excising it, or chemotherapy by kind of reducing the tumor burden, or radiation therapy by giving it a blast of radiation. And what I specifically have been doing is internal radiation therapy with nuclear therapies. That is a mainstream which just addresses the top of the iceberg. And when we're dealing with cancer, there's usually something what we call a carcinogenic impact, which needs to be stopped. It's not necessarily lung cancer with smoking, but there's so many other things. It could be oxidative stress, it could be nutrition deficiencies, it could be so many other pathways. And even as of today, I think what we don't know about cancer is a lot more than what we know.
Yeah.
Every year, every day, we are discovering new things, updating previous protocols. So the addressing the root cause of cancer, looking at all the pathways, the tumor terrain, that's where having this supportive system of care on top of conventional, which could be not just palliative, which is pain management and end of care life, but there is a lot which we can do in terms of increasing the survival and also quality of life. There is definitely a role, a place and priority for such an integrative approach. And even when we deal with, I've been doing PET-CT scans all my life, and we see stage 3, stage 4 cancers where even conventional medicine has no real answers or a solution. And quite often patients have walked up to me and asked, what next? Can we try something else? Or even when their priority or concern is more about quality of life than the quantity of life or extent. I think there are so many solutions which we can give in terms of reducing side effects, in terms of giving them more energy to deal with at a mitochondrial level. Even more and more these days, we are seeing that cancer is not just genetic. Less than 5% is actually being contributed to genes, and the bigger percentage comes in from lifestyle and environment. And I think lifestyle is become a certified lifestyle medicine physician, and that's what my focus is on, to see how the lifestyle parameters which are known to turn on and off the genes, they can kind of keep a check on that, and also to reduce, as a functional medicine physician, to reduce the environmental toxin impact of carcinogens, to kind of bring down that the influence, which is what makes the cancer cells turn berserk and start into this cancer cycle and go metastasize and such. We have conventional medicine, and then we have a lot of older healing sciences, be it Ayurveda, homeopathy, Chinese herbs, and the newer energy medicine. We are looking at quantum energy, and that's the new frontier as well. So all of these together, many people are practicing this here and there in their own silos. I think I see a huge gap between these two, and I think as healers, it's our duty and responsibility to kind of bring those together with the single purpose of healing, or helping the patient in mind, and not just working in silos, doing what we are trained or what we know, or making that as an individual offering. So in a hospital, we have all these specialties working together, and then here in the integrative center, it's so great to see every other possible supportive modality, energy healing, natural healing, everything is coming in so nicely. And you also have the main cancer doc, a specialist coming together, bridging that gap, working, referring back and forth, making sure, depending upon the stage and type of cancer, which is the most important factor in determining the treatment. What type of it, what type the cancer is, when you look at it under a microscope, is it an adeno or a sarcoma, whatever type of a cancer it is, and what stage it is. Is it stage 1, stage 2, has it spread, where has it spread, is it infiltrating, TNM staging we go through, and the organ system. So all these things we are looking at, both with the conventional lens and also with the integrative lens, which can work together. I think that's integrating this together is, I think, the best way forward.
Yeah, it's a great point. So it's not this or that.
Exactly.
It's this and that, and meshing them together. And I think that's it's well said. You did a great job with that explanation, because getting back to that pillar 2, we have a lot of people that would love to do it naturally, right? And there are some where, to your point, they're staging and what's involved. We might say, look, let's give it a few months. We'll keep an eye on it really, really aggressively with the testing and the follow-ups, and we'll do it with this less invasive approach, and utilizing things like high-dose vitamin C and hyperthermia and some of these natural healing modalities that can work, right? The caveat is always, is that enough ammunition to do the job? And that's sometimes the gray area. So like I said, and I think you would agree, I'm not saying it can't be done, but a lot of times, I've been here almost 7 years now, and I've seen that the this and that, not this or that, works really, really well. And I even came here, I tell the story all the time, when I came here, because of the experience I had with my dad, I was very much against, the conventional hardcore, say, chemo and such, because I saw what it did. However, when I started to see, to your point, the integration of supporting the terrain, supporting the cell health, the immune system, oxygenating, right? Building almost catabolically, or what catabolically is breakdown, but anabolically building the tissues while they're going through something like that. People had good energy. They were strong. They felt good, and they're still getting the cancer killed, which is a great win-win. So that's my personal experience. But seeing it live on both sides, and then going, oh, there's definitely a big need for the integrative part of this.
It's not alternative. I think it's complementary.
It's complementary.
And sometimes it could be alternative if the patient chooses. Some people just don't want the other things. So, but it's a combination of both, and I think that distinction is very important.
Agree.
You're putting there the best available in every single modality, and what matches best for that particular patient, and everything under one roof. I think that's the beauty of it.
Yeah, I agree, and with that point, using the data to guide us as well. So patients will come in, and I'll tell them all the time, look, we're not going to decide anything necessarily, because they're worried about, if they're worried about chemo, or they're worried about the side effects or whatever. So let's just let the data guide us. And if it looks, like, well, we really need some stronger oomph to this, then we'll recommend it. But it's using the data and using the DATAR and the Fulgence and the RGCCs and those tests to allow us to say, look, if it were me or a family member, and you all know the way we think, we're very conservative in our methodology from a healthcare standpoint or approach, but we're not naive. And that's the beauty of it. So we'll give you, I always say, we'll give you our best answer based on what we're seeing and some of this advanced testing that we're doing. So with that, then you get into briefly pillar 3, which is all that supportive care, changing the cell environment that you talked about, plus supporting the body through the kill phase, right? If you're doing chemo, surgery, radiation, anything like that, that's boosting the immune system and oxygenating the cell, alkalizing the cell, increasing the voltage or the energy of the cell, like you said, energy, right? And then looking at the nutrition, intracellular nutrition, supporting that. All of a sudden, what you have done is change the environment that made it conducive for cancer, but also supported the cellular health as you may be going through some of this care. And I honestly, I don't think there's a better answer out there. It really, as long as it's thorough and well thought out, people do well, and we see it every day, right? So I think that's, again, going back to the integrative part. And then finally, and I'll close on this, are the causes, right? Is it bacterial loads and viral loads? Is it candida and mycotoxins from mold, which are fungi? Is it parasitic? Is it heavy metals? Is it toxins? All these different things create inflammation, which creates oxidative stress, which then damages the cell. And then that's when bad things can start to happen. So we want to get into the causes, both pathogenic and then getting into metabolic, like your hormone and your stress, cortisol, your DHEA, your pregnenolones, all those stress hormones, plus your sex hormones, thyroid function, and dysglycemia, which is blood sugar dysregulation, and methylation pathways. I mean, the list goes on, but you get the idea. We're looking at why the cell that was functioning really well now can be overtaken, by cancer, basically, and that change that happened. So again, if we start doing all these things collectively, we basically now put 10 chapters of the book together, where the one chapter could be that conventional approach, to your point, Doc, and then the other 9 chapters are the complete book, which gives you, honestly, the best upside probably possible, right? So that's my 4-pillar. I hope, if you're new, hopefully that makes some sense. I know if you've been here, I know you're probably tired of me hearing it, or tired of hearing me say it, but I do think it's vitally important based on the feedback that I get consistently. So, having said that, let me introduce Dr. Shankar, okay? And I want her to tell you a little bit about her story, because I think we heard it today at lunch. I think it's a really good story as far as what she's done a lot in her career, or most of her career, and then the shift that she's made. So without further ado, I want you to let the audience know a little bit about your history.
Yeah, sure. Hi. I've been watching this cancer conversation from the other side. It's the first time I'm here on this side of the table. So I'm basically a nuclear medicine physician. Nuclear medicine is very much like radiology. We do a lot of scans. We are very organ-specific functional imaging for every organ system in the body from head to toe. You know, the thyroid, the brain, the heart, the kidney, you name it, we have a scan for it. And we also use the same radioisotopes to treat as well. So it's medicine, it's not just imaging. Most common things which we treat is like thyroid cancer, prostate cancer, liver cancer, and neuroendocrine tumors as well. And we also kind of localize, we do sentinel lymph node imaging to make sure if at all the tumor has spread to the sentinel node, which is the first lymph node which it goes to. And if that is negative, in case of a breast cancer, you could do breast conservative surgery. So we kind of guide the treatments in terms of how extent or deep the surgery should be. And we do this not just in cancer, we also do it for most of the lifestyle disorders like heart disease. We do the heart scans, we do thyroid scans to look for thyroiditis and such. Every organ system at a functional level, at a metabolic level, at a cellular level, which sees a little bit more beyond what meets the eye in terms of comparing it to like a CT or an MR, which looks at anatomy, the size, shape, and the location, if you will. We look at the function, like if you have 2 kidneys and if it's a renal transplant patient, maybe one kidney is functioning better than the other, even by 1%, it's a matter, that decision, it makes a difference in the decision. So which is the donor and which is, you know, which one you're going to keep. So we can go to that minute level to kind of quantify the metabolic processes in the body. And I think I've been doing this, I trained here at the Wadsworth UCLA program in 1999. I was practicing here in the US for a few years after that, and then I moved back to India, where I've been doing mainstream nuclear medicine, heading a department in a couple of multiple multinational hospitals. And about 4 or 5 years ago, I was diagnosed with diabetes. That's when my journey into the other side, which is lifestyle medicine, started. And initially it was more experimental, I would say. You know, I was trying to see if there were other choices, other things which I could use or do to keep my sugars under control without really taking medications. But after that, we've been seeing good results, not just with myself, many of my other patients or other colleagues or family members. We are seeing good results, and that's led me to dig deeper and dive deeper and understand more, learn more. And I think there's so much research coming up. There is truly a paradigm shift in how healthcare is going to be coming out. There's big data coming in, a lot of biohacking. We have so much more touch points or data points which are scientific, which are proven, and it's almost like many years ago we only had the map, right? And we just had like a map. Now we have a Google map, and we have a lot of things. In the same way, I think that's what functional medicine has allowed us to do. There is so many advances in biochemistry and the omics, the metabolomics, transcriptomics, genomics. We have so much new data available now, which we can derive and use in our clinical practice and customize our protocols to that particular patient, personalize it. I think we need to catch up with all of that. So I've been training a bit in that as well. And I think it's great to see centers where everything is being made available under one roof, where especially for cancer patients, they have a lot of emotional anxiety, and there's so much they're already going through. And even if they were to seek such other solutions, it would be in so many other places. So if you can bring everything under one umbrella, I think it's a great one-stop shop, if you will. So history, that's about 5 years ago, you said, kind of started the functional medicine. I got trained in lifestyle medicine. So I am a nuclear medicine physician, so we do a lot of thyroid scans and any kind of parathyroid. So I know a lot of endocrinologists. I speak on their forums nationally and internationally. Every person I called or spoke to gave me the same medication. They said, take this for 3 months. if
when you were diagnosed with diabetes.
Diabetes.
So
My
within your
hemoglobin A1C
world
was,
of
it was
gotcha.
7.8.
Yeah.
And they said, take this. If it doesn't come down, we'll either double the dose or
Sure.
we'll, that's the approach. Nobody really looks at the root cause.
Yeah.
Why is the sugar high, or is there any lifestyle parameters? Lifestyle. There's so much you can do to kind of control your sugar levels.
Sure.
That was not even put there, or and it was just
it was an eye opener.
Yeah. It was an eye opener.
Yeah.
It was an eye opener.
Most of us have some type of history with that, whether it's with patients or whether it's with family members or yourself or something like that, where you just went, something's not making sense. Let me open up the can of worms, so to speak. And then when you open up that or go down that rabbit hole, you go down hard.
Right,
I mean,
right.
it's a never-ending process, which it's fun, it's good, but it's a continuum, which is great.
It was metformin. I remember the medication. So I looked it up. The side effect says, bitterness in the tongue. That's a side effect. And I already taste it even before I took the medication.
Yeah.
So I think after that I stumbled upon this subject called lifestyle medicine. The American College of Lifestyle Medicine has this certification, and then there is no turning back. And you're able to do all the things, and you're seeing your glucose levels come down. And it's like, why didn't anybody even teach me this, or why?
Right.
I think what has happened in the medical industry is we doctors, in a way, we are trained as like soldiers. We are trained to kind of mop the floor and not really turn off the tap. I mean, it's overflowing water. We are trained that way. We're trained to just be ready with our ambulances. When patients are climbing these steep cliffs of diseases, when they fall off the cliff, we are ready here in our ambulances to take them to the hospital. We are never really taught to build bridges or fences, to stop them from climbing those cliffs. So I think that's kind of, if we can do that, if we can address that in terms of lifestyle, what can you do? And that's what I did. I know my diet, my exercise, my sleep hygiene, stress management, positive psychology, substance abuse, which was nothing for me, but these are the 6 pillars of lifestyle medicine which you see. And I trained in that, and I was able to implement that. And then some other people in my family had gut issues. We've been struggling with that for years, and one of the main people who released my book happened to have consulted the top functional medicine doctor here. So, and then I trained in that as well, and we're seeing good results. I got certified in that. So it's been, one step at a time.
It's a journey.
It's a journey.
Yeah.
It's a journey.
It's a journey. You're learning every day, growing, learning, and then you're seeing patients, and you're seeing the results.
And you're seeing the results,
change.
I think, and you're being convinced, what, it really works, Why is this gap even there? We should all be working together, just like in a hospital you would refer a kidney problem to a nephrologist or a cardiac problem to a cardiologist. So we don't have some answers in the conventional system, and we have answers here. So we should, kind of, I
agree. I think my experience with a lot of friends in the medical world and just acquaintances and even colleagues, I'll call them, they would tell me, they said, I think the system would need to change.
Absolutely.
Because these well-meaning doctors, very caring doctors that I've met and have come to respect immensely, are byproducts of the system. So when we would start to talk initially, this is years ago, I have a few people in mind, it was very much like, they said, look, if the system wanted me to know that, right, because they're the gold standard, they would teach me.
Correct.
And that was their belief system. And then over time, I started to introduce some things to them. They started to look more and deeper, just like you did. Had some things, started to go down that, that rabbit hole. And they then were like, geez, once you start turning the page, it's hard not to go back. You can still use the conventional knowledge, but it's hard to not keep thinking forward and just dismiss what you learned, because it's almost too common sense
Yeah.
too,
Yeah,
right?
yeah,
To
yeah.
put all that together.
Yeah.
So I think they're well-meaning doctors, because I say this to patients all the time. I had to learn this over time. They're very well-meaning. It's the system that really needs to change. And I think we saw that with, the pandemic. Looking at how it was handled, I have no problem necessarily with using certain things, however, certain tools, but there should have been a lot more education on lifestyle, on health, what you can do to build your immune system, because as I've learned over the years, what they talk about is the virulence of an organism versus the strength of your body. And I think from what I learned years ago, 80% of these organisms are self-limiting, which means if I have a strong, healthy body, I can get over this fairly quickly. If that's 80%, then we should probably be focusing a lot on this and this too, and then work together to make sure that we have both going, and then the human body should be able to take care of quite a bit. Now, again, to your point, as things break down because of this environment now that we live in, and if we could be better at understanding the environment, understanding how to cope in this environment, whether it's stress and trauma and infections and chronic, toxins and chemicals and things like that, then we can keep our body strong, but it needs a little help probably these days. So anyway, without further ado, are you okay if we start opening the questions?
Absolutely.
Yeah, let me go ahead and share everything, gang. We've done our introduction, so we'll work through here. I'll leave this up, and then what we could do so you can read a little bit more. I'll leave it up for a minute or about 20 seconds or so. That way, if you're watching the replay, you can read over it, or you can stop or whatnot. So but Dr. Shankar went through a lot of this, right? You're comfortable with that?
Yes, absolutely.
Yeah. Okay. All right. So let's go through. I'll do the prevention part later, because I do want to get into some of this. These questions. So we talked about the education background, inspired the interest in integrative medicine, more about how your own health struggles gave you insight into the power of lifestyle changes on holistic medicine. Great. All right, treatment philosophy. I think you pretty much, it's the integrative.
It is
right?
integrative. I think it's like, conventional medicine, I think it's more like you're specializing, you're knowing more and more about less and less. And the concept is very systematic. I think now, like I said, there's going to be a paradigm shift in how we look at the human body. It's systems biology, how every organ talks to the other. It's not just there's one pill for every ill. I think we need to address the root cause and look at balancing the imbalances. It could be assimilation, it could be the gut microbiome, it could be detoxification pathways, toxins in the body, cardiometabolic, insulin resistance. That itself is a huge contributor to cancer. A lot of autoimmune kind of allergies, immunity, and hormones. There are some specific cancers which are hormone driven. And last but not the least, energy, mitochondrial. Even cancers are not just genetic, there is a mitochondrial energy component to it. I think we have always looked at the human body as a biophysical or a biochemical. There is the metaphysical or an energy aspect to it. And even with energy, be it electricity, gravity, what have you, we always, what we know till now is more from a effect level, not at the cause. I think we still don't have all the answers and technologically answered, nor the tools or the sensory perception to kind of quantify or map it out there. What there's so much in this energy space which is evolving. But we know DNA responds to energy. We know that. We are learning a little bit every day, and I think that opens up a huge frontier to understand, and trying to heal the patient as a whole. This holistic approach. And trying to prevent before it actually gets there. It's like this curve. I look at it like this curve, where conventional medicine, looks at the top part, the tip of the iceberg, if you will, where we have surgery or medications, what have you. I think the next bridge should be either lifestyle or functional medicine, where you are looking at it from a preventive angle, where you're not letting them go there, or you're trying everything possible before they go there. And in that space, you have finer tests which look at a pre-diabetic stage or even before it becomes labeled as a disease in the main system. We have a lot more things at a metabolic level which can catch or pinpoint that it is headed that way.
So, and a lot of the energy testing can do that. Yeah, great point.
Yeah, and I think that brings in that thing. And we also have a lot of supplements in terms of nutrition, herbals, nutrients, minerals, which are simple and not they don't have that much side effects as like what you would be getting if you were doing like proper conventional medications or things like that. And I think and even below that would be lifestyle, what you have under control, what you can do before you start climbing up that ladder within the 6 pillars. So that would be the preventive angle. And even when somebody crosses that bridge and there is disease, we need to stop putting band-aids and just addressing that. We need to look at what is the root cause, what actually has led to this. And once we address the root cause, I think everything kind of falls into place. It's if you're diabetic, if your eating habits are not right, or if your exercise routine is not right, if you can fix that, then your glucose levels are not in a level where you would be labeled as diabetic, right? It is like either pre or normal. So if there is no label of a diagnosis, then it's almost like you're calling it reversal or in remission, but you got to keep doing what you need to do to keep you there. That's lifestyle, and making your patient do it in a simple, easy, possible way. So that would be my treatment. I think philosophy.
Well, you're going to fit right in here. That's for sure, because that's honestly what all of us, believe, firmly believe, see it work every day, live it, eat it, breathe it, sleep it, and then all of you that come here are craving that. You're looking for that. So the beautiful thing is, I had my own practice for many years, and I think I was at early, like the forefront of doing this, and it was a bit of a struggle where I would say trying to create the value to patients that this wasn't as mainstream in say 2005, right? And then trying to teach them and educate them on they would have to be an active participant in their health, and then they would have to take the steps in order to change their diet and do all these different things. It was somewhat new, so it was a little bit more, I would say, convincing them to do it. Where here, the biggest thing over the years that I've learned, and here with, I believe, the message that's out there from the clinic, people, I've never had to almost over-convince somebody to do some of these things. They are looking for it when they come here, which is great, because you want that synergy. You want to be here with your patients, that you're not ever talking down. You're really working synergistically with that patient, really to get to the same end goal, which is nice. That's one of the main things I love about being here, for sure. So, okay, let's see. Is there anything else you would like our viewers and patients to know about you?
Oh, well, I'm an avid gardener. So an organic gardener.
Wow.
So my garden won the national award, and I think that kind of leads to my journey here. That's why I want to talk about it. So doing what I do, which is PET scans, and many patients come up to me and ask. They have absolutely no risk factors, no non-smokers, and we are still seeing a lot of these cancers which don't make sense. And there's a lot of toxin burden, liver cancers, especially in the gut or in the kidneys, which are organs built to take out the toxins from the body, and it doesn't make sense. Families, we see these clusters, and that's when I started reading. There's so much pesticides and
herbicides
and fertilizers, so many things which we are using in the food ecosystem. That kind of shifted me to revamp my garden. All the landscaping went out, and I started growing food. So that kind of connects the dots for me to what I see and what I practice and what I believe in, kind of comes together. So
So you won an award.
My garden, yes.
Really?
Yes.
Tell us a little bit. I know I was intrigued, so tell us a little bit about that.
So it's an organic garden. So we do kitchen composting. So everything is 100% organic. I use no fertilizers. I must have around 15 to 20 fruit trees, and I must have grown up more than about 200 types of vegetables, like exotic and such.
Wow.
We do grey water harvesting, we do rainwater harvesting. So trying to build an ecosystem. We have a lot of birds come in. I have a little small space, like my backyard space. It's a fun space. Gardening itself is very healthy. You can get some sunlight and you can do some exercises, if you will, and it's bending down and doing stuff. So it's a lot of fun, and we try to do it organically completely. So
we might have to get that on videotape and show everybody one day. We'll get there, maybe. We'll see. That's awesome. I love that. I might have to ask you some questions about that. Okay, so we'll dive into some of the questions here. Okay, so first one, I am fighting breast cancer for the second time in 30 years, this time functionally. It's going well. What I need help with is chronic fatigue syndrome for 33 years. It came on rapidly a few weeks after a bout of the flu, likely a reactivation of Epstein-Barr. Recent testing shows EBV, IgG, IgM are high too. Okay, but NA is okay. Mitochondria operating slowly. Yep, I'm about 50% functional. Any suggestions? So
that's a lot of information there.
Yeah.
I think breast cancer would like to know where, when, and what type and stage. That would be my first question. Fatigue wise, a lot you can do lifestyle wise, diet, nutrition, phytonutrient rich diet, exercise that helps you stimulate all the mitochondria. That's good. Sleep hygiene, that's your restorative sleep. I think that's an important one. Stress management, I think they have a lot of things happening here to help you with that as well. The EBV, IgG kind of need more details. It's hard to just comment with just that. For mitochondrial energy, I know we have the tests available to, we have the oats and 3 or 4 testing is there. It checks mainly for the oxalate formation and the mitochondrial function. We could even look at the nutritional profiling, which the oligoscans do, and I know you are the expert on that. Some detox markers. It's a lot there, but there are some supplements also, NAD, CoQ10, many of them. But like I would like to say, this is not like a medical consult, so I would, it's just general advice. I think some testing, definitely lifestyle, first of all, a lot of things which you can do with your lifestyle, and some functional testing and some functional supplements, I think would be the first few little steps. And if we know what stage of cancer, if we have any more advanced tests, we could even look at it from a preventive angle, if there are any circulating tumor, I think that would be the second.
Yeah, I agree. I think the mitochondria itself, there is a term called mitochondrial defect, but it's secondary, right? They might use that term because it's affected, and a lot of times it would be affected by inflammation, oxidative stress, almost flu-like, right? And something like this, yes, the Epstein-Barr could be a big factor. Going down the road of, this is something, methylation, I would definitely look at the methylation pathways. We would look at a little bit further into other viral loads, maybe even, heck, sometimes Lyme, with something like this where it's that fatigue is there, something like Lyme and mold. But to your point, this would be something that would probably have a laundry list of tests that we would do. You mentioned cellular nutrition. We would see, some of the main things we would look at very early on. But there is something that's getting in the way of your mitochondria producing energy. And it could be the Epstein-Barr, that could be the smoking gun. And then, how do we get rid of it? So that's the other part of this, where in a facility like this, we're working on potentially using EBU, right? Which is, the blood, really it's ozone, blood out one arm, through the machine, 7 grams at least of ozone back in the other arm, and that blood's really cleaned up, if you will, and ozonated, which is rich in oxygen. So that is a big factor in helping reduce the burden of Epstein-Barr, which then also the oxygen can clean up the cellular debris. You combine that with doing some intracellular nutrition testing, and you can do some methylation testing, and you can do, now all of a sudden, you might have 3 or 4 things that pop up as far as causes that we could start working through. But this is one of those functional med where we might have to go down a little bit of a rabbit hole and look at a number of different things. But I will tell you, a case like this would show up in our office routinely.
Yeah,
so
it's like a routine.
It's a routine.
Yeah, and the fatigue, again, it's the treatment for cancer, chemo, that itself could lead to and top up the existing fatigue. Possibly there is something else going on at a mitochondrial level which would have possibly contributed or started the cancer process.
Yeah,
possibly.
But this is a very typical patient that we see, and then the workup is basically the combination of a lot of things that we talked about. Once we find some of the answers, and you start fixing things, that's the approach. It's rarely singular, honestly. It's usually multifactorial, but there could be some strong smoking guns in there. But it's just figuring out where to start, looking at those tests, and then start chipping away at what we find. So hopefully that helped. But yeah, a clinic like ours or this clinic, we would be able to do a great job with something like that. All right, is there a way to test for mesh compatibility with the body? This is for a hernia. Yeah, it's a good question.
Yeah.
Okay. I tried to look up some answers. I couldn't find much, but maybe you have some insight.
Yeah, I think hernia meshes, it's the mesh itself, it's a medical device as per FDA. And the most common, it's a polypropylene mesh. That's the most common type of material used in the mesh. And what you want to look for is something which is lightweight, which has large pores, and it has minimal surface area to hold it. And you really want something which is monofilament, which is either a PP or a PL. Unless unless when it comes in contact, where are they going to place this? Which area is the hernia in? Is it an umbilical, inguinal, many other places? The diaphragmatic, where the hernia is, I think it could be. There were some brands which have been recalled. I think those are the ones which you want to stay away from. There was one, I think, Atrium, which because it was kind of sticking to the package itself even before they put it in. There was something with the brand Componix. The tensile strength of the material didn't pass the QC test. And the Ethicon Proceed, which had a high recurrence rate, it didn't do well after they put it in. The hernia kept coming back. So I think these are the checks you might want to do, and typically I think this would be done by the surgeon who would be doing it. Mainly they're looking for mechanical compatibility, tensile strength and such. Think that those are the things I would go for. But energy wise, perhaps there might be where I know John and Scott. Maybe there is something which they can
test energetically to see if your body's compatible. That's a good idea. I didn't think of that. I was looking online, almost like you know how you eat for blood type, right? I was looking for something like that, an answer where is there a way, but I honestly couldn't find much. But that's not a bad idea. Energetically, they might be able to test to see if this mesh, and you might have 3 or 4 different types of meshes maybe, and then they can energetically test. That might be the most.
The practical limitation would be you would have to physically bring it, and you would have to buy it or give it back to them with the package.
And then there could be the one that performs the best, but it's not as compatible. So that's a tough one. I'm not going to lie. So, but hopefully that was good. I'm glad that was a good answer. Let's go. Okay. All right, sensitivities, drugs, food, chemicals, and the environment. Doctor found the ANCA antibody, PR3. They've been so worried that I might have vasculitis, completely dismissing my multiple allergies. Could this be antibody could be formed from severe allergies, particularly certain meds? Side note, severe sinus infection a while back, and I was treated with Z-Pak, Levaquin, Cipro. The last 2 meds made me extremely ill. A couple years later, found out my attic was full of mold and air. in the air conditioning unit. So
okay.
Yeah.
So I'm reading a lot of antibiotics, which could have disrupted the gut microbiome, which is an integral part of your body's immunity. So I'm thinking that, and is there a connection between vasculitis and allergies? Yeah, those are the antibodies. There is a panel, ANCA, PR3, and the MPO, the peroxidase. That's the common 3 panels which we do, and if that's affecting the gut, commonly we see that with ulcerative colitis too. So I'm thinking that. I would like to know more symptoms. If there is numbness, if there is any other kind of a rash, if ESR was checked, if HSCRP was checked, if there was a protein in the urine to see how severe it is, if a biopsy was done. Those are the things you would do to before you would think about vasculitis. And again, a lot of these markers help you filter out. It is more like a
deductive.
It helps you.
Process, a detective process, if you will.
Yeah. And the treatment is based on your symptoms and a combination. So, but what could be addressed here to check on your gut microbiome? If there is a dysbiotic picture, we could do that. If there is any autoimmunity, we could help you boost the immune system with a lot of adaptogens and herbals. We could do that possibly. And mold. We can test for mold, which could be a huge factor, and some remediation if at all that tests positive, and some antifungal there.
What you're getting is what they call most likely mast cell activation, right? So the mast cells are one of the first cells to show up at an immune response, and they burst and they release a lot of prostaglandins and histamine. So when your histamines are high from this chronic reaction, then the sensitivities are going to be very high because your immune system is overworking. So basically what you're describing is your environment around you, you've lost a buffer to. So you've lost your threshold. So the way I explain it is, if this is your immune threshold, and say I have no infections and a good clean gut, no mold, no this, no that, I can then eat this and breathe this and do this, and I'm still good, right? Because I have this buffer. But if I have all these things going on, I might start right here, and I have no buffer to my environment around me. So anything I put into my mouth, anything that I breathe, I'm sending off or firing off this immune system even more, and it's crossing basically your threshold. So you have no buffer. But there has to be things in your body that are causing this chronic immune reaction, that are creating this, what they call mast cell activation. And there's where your sensitivity is coming from. Most likely, the most common that we see with this is mold, to be honest with you. Now, I will tell you, the other one that we see a lot with this is Lyme, okay? Now, Lyme is a whole separate topic in and of itself, but it's not just getting bitten by a tick. There's something called cat scratch fever, right? Cats, most cats, I'd say, they say 40 to 50, even more % of cats carry this cat scratch fever, which if you do get scratched, for example, and they're carrying some of these co-infections, then it presents, because these co-infections are like Lyme co-infections, it presents like Lyme. Now, I'm not saying you have that, but I'm saying when we see, these high-level hypersensitivity reactions, you definitely have something chronic in your body, right? That's firing these reactions up, and it's causing an overactive immune response, which is chronically, which is creating very little buffer. So it definitely, we see this a lot, and we would go down also the road of methylation and epigenetics as well. So I think, personally, I would start looking gut for sure. I'd be looking at methylation. I'd be looking at mold. I'd be looking at Lyme. Things like that. Marcons can do this. It's a staph infection that is antibiotic resistant. I would probably go down that road. And to give you a quick antidote, there's a really good book called Toxic by Dr. Neil Nathan. This explains, his entire book is really about this, and it is either Lyme, mold, too many toxins in the body, and the immune system just overreacting.
Okay.
So there's definitely a lot, because we see this case often as well, and it's exactly, you know, where we would be looking, or where you should be looking. So you really have lost your sensitivity, you lost your buffer, or too much sensitivity to your buffer. So you have anything to add? Good?
No, I think good. Vasculitis, again, from a PET perspective, PET CT perspective, we can, that's a scan which we can document the bigger vessels, the size of the vessel, you know, the arch of the aorta, or the temporal arteritis. That could also have like a component there. So depending upon the stage and severity, we could, you know.
The likelihood, good point, the likelihood that the vasculitis is secondary to the inflammatory response that you're getting. So I think you're right, when they're completely dismissing the multiple allergies.
Exactly.
No question, question, you know, doing this a long time. That's a big deal that has to be looked at functionally. And I think if that's done, this is a situation you might have to, you know, they might have to address the vasculitis, medically speaking, right? But then if they do that to keep you safe, and then we work on the causes, or somebody works on the causes, now I think we could get rid of both, you know, potentially. Yeah. So hopefully that helps.
Steroids is not the only answer
for
vasculitis.
That's exactly right. So, but they might be a necessity. That's what I've learned over the years.
Absolutely.
That
but
we
you
use
could
these...
reduce the dose and make sure the inflammation goes down, and you don't really need those dosages.
Absolutely. Yep. All right. So hopefully that helped. That's one we see often now. What do you recommend for women with the annual breast screening? Mammogram, thermography. I hear pros and cons to both.
Okay. So So I think the US PSTF, the US Preventive Task Force, they have their guidelines, and it's a grade B recommendation. That means there is moderate evidence to suggest whatever they are suggesting, and they recommend by, you know, once in every 2 years if your age is 40 to 74 years of age in women, and depends if you're more than 75, they have a specific guidelines, and dense breasts also. The B is the moderate evidence of this thing. But it also depends on family history. If you have a family history of breast cancer, I think you would want to start as early as age 30. There are some countries where they're not doing this. There is the Canadian Task Force, there is the Switzerland, I think Sweden, I think it varies across the globe. Personally, I think it's always good to do a basic, self breast exam monthly, maybe a clinical breast exam every once in 6 months, a mammogram or an MRI, or even the QT, which uses sound imaging. So the main concern with a mammogram is the radiation, right? It's you're throwing in X-rays, which itself is carcinogenic. So that's the main concern, and not a very comfortable procedure.
Yeah.
What the QT scan, which is now, I think, very few centers, and I suspect that is going to become the norm going forward. Absolutely. So they float the breast in a bowl of water, and it's sound waves. We are using sonomammograms for dense breasts already, because a regular mammogram cannot pick up, and it can even miss lesions in the axilla if it's like an axillary tip or an axillary tail. So I think that's a great alternative. No matter what, I think doing a self-breast exam is like the key, and you can choose. Thermography, on the other hand, it is picking up heat waves. It's a temperature, right? And it could pick up anything. There are no guidelines as of today. It could pick up hotspots or thermal hotspots, which could be inflammatory. So there is no real way you could differentiate between an abscess or a tumor. What mammogram can do is we have the BIRATS classification, 1 to 5, intermediate. So that kind of, we have some specific guidelines how when would you biopsy, or how frequently would you follow up. That's the positive aspects to it. But like I said, I think things are going to change with the QT type of scanners available, and which gives you not just comfort, also zero risk of radiation exposure. I think that would be the path forward, I would feel.
Yeah, I agree. I think I'll touch base just a little bit. Thermography is a good tool. It's very non-invasive. but I personally wouldn't recommend it as a standalone. Now, if you're younger and all the other concomitant factors they call it, right, would are good. You're very healthy. You're using thermography up until a certain age. Might not be a bad idea. If you see changes from one scan to the other, then you would follow up with maybe an ultrasound or an MRI or a mammogram or something like that, QT imaging. So you can use it. It's not bad, but I think standalone, I'm not sure that I would do it as a standalone, but I like it, right? And I like it in conjunction. The other part of that is utilizing, to your point, QT imaging is very, very good nowadays. It's going to catch on. I think it's the norm moving forward. MRIs are actually really good. I know some people that do QT imaging and MRI and rotate those every 6 months or so. And then the other part of this too is some of the testing that is now available. So if there's ever a worry, say there's a family history or you're not sure about some things, you're doing these, you have a good schedule for imaging, and then you can do liquid biopsy, right? The circulating tumor cell testing, RGCC, some of the other ones that are Signatera, things like that, to just make sure they're good. You can also have doctors run, your CA 15-3, 27-29, and kind of do a full screening, both blood and imaging. Now you're probably looking at a very solid screening tool, right? Collectively. So I think nowadays, from what we see daily downstairs, I think something like that is a good idea. You have your scans, you do some, say, yearly blood work, and now with the liquid biopsies, like I said, the RGCC, Signatera, it makes it really easy to be able to thoroughly, I think, screen. Fair? So you put all those together, and now you're humming. Now you can sleep at night going, all right, I feel comfortable that everything's good. And then again, to your point earlier, you put the wellness techniques in play. And nowadays, even for me personally, going down the road of methylation, going down the road of detox, and looking at toxins and chemicals, and some of these things that, even though I feel like I've done well with my health overall, I'm probably missing some things too, and that's the wellness part. So getting deep into that dive, because we do see patients that come in seemingly very, very healthy, right? I mean, have done the work. You can tell they look good, they're healthy, and they're still coming up with some of these cancers. So it is because we're missing some things, or we miss some things, or they miss some things with the deeper dive.
Absolutely. And what is also more important, not just to catch it early, to also make sure you're doing everything possible for it not to even happen. Whatever is practically possible. We can't really do everything all the time, but your diet, this is a hormone-dependent cancer. So making sure you're eating the good non-hormone induced type of foods, exercise. There's enough evidence to show cancer patients who did the right kind of lifestyle after had a lower level of recurrence rates. So lifestyle modification, stress management, these are big tickets, I think, which everybody, 100%. Even alcohol, a glass of wine increases risk. I've been reading. So I think, just paying more attention and being mindful of our living practices, I think.
I use when I'm talking to patients, I'll tell them, they ask me what I do. I said, look, my mentality is kind of like depositing in a bank account. If you do enough depositing, once in a while you can withdraw, right? And you have plenty of buffer there. That's just how, throughout a week, that's what I'll kind of go, hey, do I want to do that? Or, how did I do throughout the week? Were my workouts good? Did I eat really healthy throughout the week? And then if the answer is yes, and I feel really good, I know it's not going to knock me down too much. I might get off a little bit and do something, right?
What use is the money if you can't withdraw?
Exactly right. So that's just a mindset that I like to use. Okay, papillary thyroid cancer 2019, bilateral neck dissection, total thyroidectomy, RAI treatment. My situation was a little more advanced. They saw micromets in the chest. Thyroglobulin levels have been stable at around low, 10 to 20 for the past 5 years. Recently went up to 30s, may also be because of TSH dosage. Do you use thyroglobulin as the primary cancer marker? I've heard mixed things from my functional doctor and endocrinologist. I would love to know what could be done at the clinic to be NED?
Okay.
Yeah, great.
So
great
yeah,
question.
a very common question. So thyroglobulin, it's something which is secreted by the thyroid cells, and it doesn't necessarily mean there is cancer, but the levels normally in conventional medicine, when I'm treating a thyroid cancer with radioiodine, the levels we go, if the thyroid was totally removed, as in this case, should be less than 10. That's the kind of cutoff. And if it is more than 10, the radioiodine scan which we do commonly shows a remnant, because it's very hard for the surgeons to get it all out, and they're trying to preserve the laryngeal nerve, or it's a delicate structure there. So usually there is something left out, and that's when we go ahead and burn it with a higher dose of radioiodine. And but even if something were to be left out, what we use it is for serial testing. If it's going up north, that's when it's like an alert sign. So that's the value of thyroglobulin. And very commonly we also see elevation of thyroglobulin in autoimmune conditions, which is usually seen by a functional medicine practitioner. So I think that's where the confusion.
Like a Hashimoto's type of.
I think that's where the confusion comes from. It doesn't mean that just because thyroglobulin is elevated that you have cancer. No, but if you have had cancer and if thyroglobulin is still elevated, that is something which we need to watch. We cannot just negate it, and we need to keep a close eye. And you are saying it went up to 30s. So I think, without having the full history and looking at the complete chart, and if they gave you radioiodine treatment, that would be at a high dose, what dose, and was a scan done after the dose? So when you're saying micromets, so where the spots lighting up in the chest, how big they were, I think these are the questions kind of, and the last point was, what can we do to be NED? NED is
no evidence of disease.
Right. So I think definitely we have the lifestyle. I always emphasize on that. That's something you can do at home. There are a lot of IV therapies, vitamin C, things like that, and testing circulating tumor cells to understand, if at all, how much. The scans just show the macroscopic picture, what you can see with your eye and you can measure, and the nuclear scans show at an energy level what is going and sticking there, if there is any tissue left. But the CTCs show even if there's 1 or 2 cells of which kind of matches that tumor tissue. So it gives you a more deep, I think it's just trying to look deeper and closer, and trying to do whatever possibly we can do to help the body support with its own immune system to fight those cancer cells, be it with IV therapies or many other modalities. I think that's where both would fit in.
I think it's dead on. So with that thyroglobulin is just one marker, right? So in our world, we might use 6 or 7 or 8 others. So to Dr. Shankar's point, we would use the liquid biopsy test, right? So that could be RGCC or Signatera or DATAR or something like that, to see if there are those circulating tumor cells. So that would be one, and they can match them to that specific cancer. And then number 2, there's additional testing like your some of your markers, nagalase, PHI, D-dimers, right? We could use other markers that can paint a picture. So I always say, hey, we could start with a blank slate. We see the thyroglobulin go up. Say the circulating tumor cells are elevated. Say the nagalase is elevated, the PHI. Now we're backing up that, hey, this thyroglobulin is up. Now we have other markers that show us. Now we can get more specific with the treatment, because it backs up the fact that now there's something going on, right? And then we can get more detailed in what we need to do, scans or anything else to really, kind of narrow it down. Then to Doctor's point is really, to get to NED is using the 4 pillars. So hopefully you're on with the beginning where we talked about getting that testing and really dialing it in, starving the cancer, killing the cancer if that is truly what's going on, and then changing the cellular environment, immune boosting, oxygen, alkalizing the cell, charging the cell, and making sure that cell has the right nutrition. So we test for that. and then getting through all these different causes, right? There's often, gasoline being dumped on the fire, so to speak, that makes this stuff happen. So we want to do that complete 4-pillar approach, and that's how you can get to that point of NED, or at least it gives you some of the best opportunity to get to that place. But if we're just using thyroglobulin and maybe they're doing, some of the things that you did initially, which may have been totally necessary, by the way, that's the one chapter. The other 9 chapters are these other things that Dr. Shankar and I have been talking about that are going to give you the best opportunity to heal, because we looked at you from head to toe.
Absolutely.
Yeah. That would be the idea. So that could be one marker, but there are other markers that could be looked at and really tell the story more thoroughly. Fair?
Yeah.
Okay. All right. So husband was diagnosed with high risk Gleason 8 at PSA 33 in early 2020. 6 weeks of radiation, followed by brachytherapy and 2 or 3 Lupron injections over 12 months. PSA is now 2.24. Just had a PSMA PET scan that showed 2 small spots on his left shoulder area. He had a Lupron injection 3 months last week. Started Zagata, Satiga today. He has some left shoulder tenderness, but supposedly also has rotator cuff in that shoulder. Concerned about this pain. Very concerned about potential side effects of those drugs. Do you agree with this treatment plan? Do you feel it's necessary to be on the prednisone also? My quick take is I wouldn't agree or disagree.
Yeah.
We would really have to, this is a full, thorough
I agree.
investigation.
I was gonna say,
But I will tell you, going back to our 4-pillar part, what I tell patients to do is if we give the 4 pillars and the details, what I think it would be a good idea is to see what you're doing of those 4 pillars and kind of see if there's some blanks to be filled in.
Okay.
And I do think there's some blanks to be filled in from maybe the testing and so forth, but also some of the treatment, because it looks like it's being dealt with primarily conventionally, which totally respect, by the way. I want to be very clear, but I think there's so many other chapters to that book that could be filled in there. So go ahead, Doc.
Yeah. So do I agree with it? I think this is a standard protocol conventionally. The Lupron, the Leuprolide, and the Abiotron, I thought I saw that somewhere, right?
Which one?
Leuprolide, and there was another, Lupron. Okay, so Zytiga. So that's the, so basically how that works is it inhibits the CYP117A1 kind of an enzyme, and how the prednisone works, why we put them on prednisone is to increase the efficacy. It kind of increases the efficacy of the Zytiga. That's the reason the prednisone is normally prescribed, and the prednisone also helps with decreasing the side effects from the medications, which could be typically it's like increase in BP, fluid retention, hypokalemia, things like that. Alternatives to prednisone would be dexamethasone, hydrocortisone, spironolactone, things like that, which the first 2 are also steroids. Maybe spironolactone could help. But from an integrative perspective, we could do a lot with adaptogenic herbs. Ashwagandha, rhodiola are most common ones. Anti-inflammatory, curcumin, omega-3, maybe LDN, some kind of energy healing. These are all commonly used modalities in the integrative space in this kind of a scenario. So it really depends if I feel it is necessary. It depends on the dosage, it depends on the side effects, and how long you're taking. And another point which I thought was important was the PSMA PET scan showed 2 small spots in the left shoulder. So shoulder, I would prefer to see the scan, because shoulder, it's like from bone through skin, right? There's ligaments, cartilages, there's a lot happening there. And a prostate cancer, typically when it spreads, it goes to the lymph nodes, to the liver, or to the bones. These are the common sites of metastasis. And if it has really gone to the bone, if the CT, corresponding CT, is showing any changes, sclerotic or live I take. And if it is truly a true positive and not like a false positive, I think I would check that, because that would be also a very important factor in determining, some of these medications, how long and if at all prednisone is really needed or not.
Yeah, there's a lot.
Yeah.
There's a lot to unravel on that one, but I think there's some more good things that could be done, whether it's here or at another practice like this, that could really help this process. And even if the need for these medications was there, the body can be supported so it tolerates them much better as well. And I think that's a big part of our philosophy is, hey, if we have to do these heavy duty drugs, if you will, that we keep up the support of the body as primary, I guess goal number one is to get the kill, but support the body as best we can through the process.
I just saw a patient earlier today with a very similar history, and it's not just prostate cancer is one of the easier or the better type of cancers we would like to see. They're slow growing, low risk and not very aggressive, and there's a lot of time and a lot we can do to kind of help it slow down and not spread further, and definitely to increase the survival, quality and quantity of life, more so quality. I think even in terms of urinary health, in terms of cognitive health, a lot of these medications affect the cognition. Age is an important factor to consider. If you're driving, there are so many other things which we can support cognition, support urinary health, which will eventually give you a better quality of life.
Okay, so I just did a quick time check. It's 6:21, so we're definitely
running.
Yeah. So what we'll do, gang, this will be the last question, and then what we'll do is any of the other questions we'll get on like we always do, and just keep going on our Q&As. But I did want to, let me just kind of get to the end. I know there's a lot there. So I did want to just, because we get questions after this all the time, the Center for Healing, if you have questions or concerns, you have active cancer, or maybe you're looking to prevent reoccurrence, the 949-581-4673 or HOPE is the number to call. That's Vicky. She'll answer any questions, help guide you, help get on board you, whatever you need. The Center for New Medicine is the preventative side, or if you have autoimmune or mast cell activation or some of these things that you want help with from a cause standpoint, the center, and Miles is the one that onboards the patients. That's the 949-680-1880 number. Okay, and then you have the other numbers there as well. We didn't talk too much about the hyperbaric or perfectly healthy store, but those numbers are there for you as well. Okay, so I wanted to take the opportunity to thank Dr. Shankar for being here. I thought she was phenomenal. I think she's going to be like just a huge asset to the clinic. Wealth of information, wealth of experience too, which is fantastic. So we're always looking to get better, and I think having an asset like her is going to be a really big thing for us. So thank you for joining. Okay, just like we talked about before, I think one of the big things, you hear me say it every week or every time we're on, the prevention part is critical. Okay, so if whether or not you feel great or you're having symptoms, there's still the concept that prevention is always easier than the cure. So getting in and having us look at a lot of these pathways, like your methylation, do you have toxins, do you have chemicals, how's your cellular nutrition? I mean, going through that process of making sure that if you do have some of these precursors that could be damaging the cell, causing the mitochondria not to work as well, and that mitochondrial is a big part of cell communication, and that's what starts to break down, then let's at least look at that and start reversing that process to make sure that cell is strong and healthy. So again, the oxidative stress is a big part of how that breaks down, and a lot of these causes that we talked about will eventually start to overrun the cell and start to cause the damage. So the prevention part we're trying to promote heavily because it makes too much sense not to. I know it's an investment of time, energy, and money, but I think a well worth it investment.
Absolutely. So there are so many mutations, you need before the cell turns into cancer.
That's right.
And
That's right.
If we can figure out what is hitting it to
Yeah.
cause the carcinogenic burden.
Yeah.
I think that's the key to prevention.
Great point, because you mentioned that there's an adaptive phase and there's a mutation phase, and what should happen is the cell should die.
Yeah.
It's programmed cell death. It's called apoptosis.
Yes.
But something or things are getting in the way of that process happening, and now replication happens. And so usually it is that oxidative stress, damaging those structures that govern that. So again, can't stress it enough. Do the best you can from a preventive standpoint. Get with somebody, if it's not us, get with somebody who can take you through these steps and really guide you so you can clean up everything that could be going on, creating these chronic illnesses. And it's not just cancer, it's autoimmune. We see a lot of different things related to this oxidative stress inflammatory process. So anyway, thank you again, Dr. Shankar. We appreciate you all. Have a great couple weeks. We'll see you in a couple weeks. If you need us, reach out. I'll be happy to help you in any way we can or I can, okay? Have a great couple weeks, y'all. Thank you.
Thank you.